A very good afternoon to everyone. Thank you so much, Dr. Vitull, and all the organizers for giving me this opportunity. So I will be talking about renal denervation as a treatment modality for resistant hypertension. Though this strategy is quite new, but let's explore. The purpose of my talk will be twofold. First, to provide and to navigate through all the clinical evidence which we have for renal denervation. And the second is to provide you guidance about the clinical utility in our practice. Arterial hypertension, we know that is a big problem. According to International Society of Hypertension, the data is very old, that shows that in 2010 approximately 1.39 billion people were suffering. That accounts for approximately 31% of our adult population, and it accounts for more than 10 million of deaths at an annual rate. And majority of this population is from the low to middle income countries. Why we are so much worried about hypertension? Because we all know that systolic hypertension is one of the leading cause for cardiovascular mortality and morbidity. And it has been found that even 5 to 10 millimeter reduction in the systolic blood pressure can lead to improvement in our cardiovascular outcomes. That's why we have hundreds of pages of guidelines from different societies, be it European Society or American College or Asian societies or Indian Society or International Society of Hypertension, and number of organizations and consensus statement, and they keep on revising the guidelines, what should be the targets to be achieved. But in spite of all these guidelines and with the availability of so many antihypertensive drugs in the real world, only BP control is achieved in suboptimal number of the patients, that is approximately 32.8% at a global level. This slide is very interesting. I introduced it because I was surprised to know that the treatment for the hypertension dates back to only 1950s. And before 1950s, it was considered an essential malady with almost no treatment. With the advent of thiazide diuretics and subsequently the whole range of the antihypertensive agents were added. Now coming to the definition of resistant hypertension, we all know resistant hypertension is labeled when the person is not having in control blood pressure as per the target with the use of 3 or more than 3 classes of antihypertensive agents, and one of them should be a diuretic. But resistant hypertension should be labeled after excluding pseudo-resistance, that is by ambulatory blood pressure monitoring. We have to rule out white coat hypertension, and the second is to rule out the secondary causes of the hypertension which may be causing a resistance pattern. The other important thing is the drug adherence and drug compliance. Many of the patients, they are not truly adherent to the drugs and they will not be taking in the proper dosage and combination. So that is one of the major reasons for the resistance. So after ruling all these conditions which can be contributing to the resistance, these patients should be evaluated and then labeled only after excluding these causes. Then coming to the refractory hypertension, which is another extreme phenotype as has been nominated and given terminology by American Association, when the patient's BP is not controlled even with the use of 5 or more than 5 groups of the antihypertensive agents, that is called as a refractory hypertension. But as the number of antihypertensive agents increase, maybe 1, 2, 3, 4, 5, we have seen that the rate of the compliance decreases. And also the hypertensive patients, they all have other comorbidities also, like statins and anti-oral hypoglycemic agents, so that will also add the pill burden. So in that way, with increasing doses and with increasing number of antihypertensive agents, the compliance is always poor. So this was about the antihypertensive agents. If the patient is not still controlled after following all the lifestyle modification and antihypertensive agents, so what will be the other options for these kind of the patients? So here comes the role of device-based therapies, and out of all the device-based therapies, renal denervation is one thing that is very close to the clinical application. And the basic idea of renal denervation originated from the fact that there is an evidence of increased sympathetic drive in a patients with a hypertension, especially in the patient with resistant hypertension, which is contributing to the pathophysiology. and it has been shown by the increase in the sympathetic nerve activity in various other metabolic conditions also, like we can see in hypertension, obesity, obstructive sleep apnea, congestive heart failure, metabolic syndrome and renal failure. And it has been found that as the intensity of the hypertension increases from mild to moderate to severe, the degree of sympathetic nerve activity also increases. So that's why we are now more focused on how to decrease the sympathetic overactivity to have a good blood pressure control. For that, the aim is to suppress the renal sympathetic nervous system. And if we look at the anatomy of the renal sympathetic nervous system, there are two pathways. One is the centrifugal pathway, which is going from the brainstem through the hypothalamus to the lateral column of the spinal cord, goes to the renal cortex, and then goes to the kidneys, where it affects the renal tubules, the renal vasculature, juxtaglomerular apparatus, and stimulation of these efferent fibers lead to release in the renin, increases the sodium ion reabsorption, causes vasoconstriction, and thus causing hypertension. The other pathway is the efferent pathway, which starts from the renal cortex, and the receptors are present in the pelvis in response to any kind of the painful stimulus, like suppose there is increase in the pressures or increase in the because of any renal colic, any pain, that leads to stimulation of these receptors. Efferent signals they get stimulated, and the pathway is from the cortex to the dorsal horn and then going to the brainstem, and which in turn further increases the efferent outflow of the sympathetic nervous system. And these afferent and efferent nerves, which are causing stimulation of the sympathetic drive, these nerves are located along the course of the renal artery. So it's very important that these renal nerves are easily approachable if someone can intervene through the lumen of the renal artery. The renal artery originating from the aorta, if any kind of endovascular approach can be approached to ablate these renal nerves through the lumen of the renal artery, in that way we can decrease the sympathetic drive. And it is important to know that these renal nerves they course along the renal artery. But here is one difference. As the renal artery is starting from the aorta, the renal nerves are little farther away from the lumen. As you can see in this figure, they are further from the lumen in the proximal part, but as we go distally, in the distal part the renal nerves are going quite close to the lumen. So any kind of ablation procedure, if it has to be very much successful, we have to focus on the distal part of the renal artery, where they are more close to the lumen and very easily accessible for the ablation. Apart from this, in 30% of the patients, we have found that there are accessory renal arteries, and these accessory renal arteries are also accompanied by the renal nerves. So, for renal denervation to be successful, not only the main artery but the accessory artery nerves they had to be ablated so as to have a complete response. Now, the pathophysiology which has been described how RDN leads to the better control. In fact, it leads to the 24-hour control of the blood pressure. It is because ablation of the efferent nerves decreases the central sympathetic activity, which is the leading cause for the morning BP surge. So in that way, it decreases the morning BP, and the ablation of the efferent nerves leads to more of sodium excretion, more of renal blood flow, and it changes. So the pattern changes from the non-dipper to the dipper pattern, which leads to the nocturnal BP control. So by controlling morning and early morning and nighttime BP and also in the daytime BP, it leads to the perfect 24-hour BP control. Now coming to the techniques how RDN is achieved. RDN can be done by three methods. One is the radiofrequency catheters, second is the ultravolt based, and the third is the chemical, that is with the alcohol mediated renal denervation. The first one to be introduced was the radiofrequency. In that, what was done, there was the catheters which was introduced to the renal artery lumen, and there is a transmission of the radiofrequency waves to ablate the nerves which are present in the adventitial layer of the renal artery. And this was the radiofrequency catheters. In these catheters, they were first introduced, and since their introduction and advent, there has been a remarkable change in the design. Initially, they used to be the flex catheter. Then came the spiral catheters, which was easy to navigate through the lumen, and the initial catheters were the unipolar, that is capable of ablating one point at a time. Then came the multipolar, having six electrodes, and the 4 electrodes which were capable of ablating at multiple points at the same time. Then ultrasound based renal denervation is basically an ultrasound device which is mounted at the tip of the catheter, and this is placed inside a balloon, and inside the balloon there is a coolant fluid which circulates so as to prevent the injury to the endothelium of the renal artery. The ultrasonic waves ablate the renal nerves present in the adventitial layer, and the circulating fluid will prevent the endothelial injury. Alcohol mediated renal denervation, there are few trials, is still in evolving phase. The trials which are non-randomized, they have shown that there is reduction in blood pressure, but we need a more sham controlled trials, and we are already on way with the name of target on med and target off med trials, and the data is yet to be released. Now coming to the trials for the radiofrequency and ultrasound based RDN. Looking at these trials, we can divide all these trials. A lot of trials has been done since 2009. The first trial was Simplicity Hypertension 1 and Simplicity Hypertension 2. These were done with the first generation catheters, and they showed that there is a remarkable decrease in the office blood pressure to the range of like 15 to 20 millimeter of mercury at 3 to 6 months of intervals. And these trials, the drawback was that they were not randomized trials. They were not sham controlled trials. Then came the first sham control largest trial with the name of Simplicity Hypertension 3 trial. And in that trial, they showed that the remarkable reduction shown in the Simplicity 1 and 2 were not shown in the Simplicity 3 trial. A number of confounding factors was found that they said that adherence of the medication in all these trials was not addressed. Because the patient in the sham group were quite adherent, they were quite vigilant during the trial process, so that's why they had good control of the blood pressure in the sham group also. Another thing was the procedures and the centers where they have been done, the operators were not very much experienced. So a lot of procedural variability could have contributed to the unfavorable outcomes in Simplicity Hypertension 3 trials. So because of the conflicting results of 1 and 2 versus 3 trials, there had been a change in the trial design. For all the further trials, it made mandatory that should be sham controlled, and they kept the primary endpoint as ambulatory blood pressure, not the office blood pressure which was kept in 1, 2 and 3 trials, because ambulatory blood pressure has less day-to-day variability, and we know that ambulatory blood pressure is a more predictor of cardiovascular risk. So any trial who is showing the efficacy of RDN has to be taken as a primary endpoint as ambulatory blood pressure, not the office blood pressure. And also the treatment adherence part needs to be addressed, like if the patient is on medicines, whether they are regularly taking with the usage of like drug testing, molecular testing, biochemical testing of these drugs. And the other thing is to check off medication also. To have a subset of the patients off medication, maybe mild to moderate hypertension, who can be made without drugs for at least 4 weeks and 2 months, and to see the effect of RDN in drug-naive patients. So this was the change in the design, and then forward later on we have a lot of trials with the main names of the spiral trials with the use of spiral catheters, and then we have radiance trials with the use of ultrasound based radio ablation. Spiral trials were basically divided into 2 major groups: spiral med-off and spiral med-on. Spiral med-off was done with the patients of antihypertensive agent to see the effect of RDN in the patients of antihypertensives. And spiral med-on trial was done on the patients who were resistant hypertension already on 3 or more drugs. The same way was the ultrasound based trials with the name of Radiance Solo without medication, Radiance 2 with the 2 medication, and Radiance Trio with the 3 medications. And these are the results of all these trials. It was remarkable to see that in all these trials, spiral hypertension 1, of spiral med, pivotal trial, Radiance Solo and Radiance Trio, there is a remarkable decrease in the office blood pressure as well as the 24-hour ambulatory blood pressure. But here you can see the degree of reduction in the blood pressure is to a modest degree. Like in office BP, it's only 9 to 10 millimeter, and 24-hour ambulatory BP is only 5 to 7 millimeter of mercury. But this trial has shown that in spite of the modest decrease in the blood pressure, these patient RDN can have a control in the blood pressure even without the medication. And all these trials, they also addressed the change in the medication post RDN, and it has been found that there was no increase in the medication dose post RDN. Apart from the daytime control in the blood pressure, the nighttime blood pressure and the early morning blood pressure would also decrease to a significant level in the RDN group as compared to the sham group. So they said that RDN demonstrated always on effect, which means that by the time when the antihypertensive effect goes off in the night time, in the early morning time, before the next dose of the other antihypertensive agents, the effect of the RDN is always on. That is, lasts for 24 hours a day. Looking at the medication burden at 1 year, 2 years and 3 years, the medication burden in terms of the number, in terms of the dosage and in terms of the classes was lesser in RDN group as compared to the sham group. Now this was the global simplicity registry which gave a very long-term data of 3 years of RDN patient. This included almost 45 countries, 196 centers and 3000 patients, and the largest database has been achieved, and they showed that the effect of the RDN not only lasted for 6 months, but as the years progressed, at 1 year, at 2 years and 3 years, there is a progressive fall in the blood pressure, whether it's office systolic blood pressure or ambulatory systolic blood pressure. So the effect of RDN is long lasting. It's not like the renal denervation effect goes after 1 year or 2 years. And in this registry, we analyzed a subgroup also, like the patients who were diabetic, the patients who were heart failure, and elderly patients more than 60 years, the patients having atrial fibrillation. All these patients, they had shown that there is a decrease or incremental effect in the lowering of the blood pressure subsequently. This is a recent data which has been published in Feb 2023, which shows a 9-year follow-up data of the RDN patients. And in fact, there was these RDN were the patients of the initial trials. They followed them, and they found that the BP reduction was even persistent at 9 years as compared to the baseline. And also they found that there was no detrimental effect on GFR. These patients, their kidney function test remains preserved even at 9 years. Now coming to the role of RDN in Asian population, we all know that Asians are more likely to have increased early morning BP and morning surges as compared to the black and whites. And also we know that Asians are more salt sensitive, as well as they consume more salt as compared to the Western counterparts. And looking at the effect of the beta blockers, the Asians are twice as sensitive to beta blockers as compared to the whites. So it has been postulated that the Asian population, because of all these basic phenomena, they will be more responsive to RDN as compared to the Western counterparts. And if we look at the safety data, no patient in the spiral trials and 1 patient in the Radiance trial had received a renal artery stent following RDN over 3 to 6 months of follow-up. The majority of the thrombosis or need for the stent occurred within 1 year of the procedure. And a meta-analysis showed that the pooled incidence rate of stent implantation following radiofrequency RDN was only 0.2%. And the global simplicity registry gives the safety data of up to 3 years, which shows that it is quite a safe procedure. So, in nutshell, the safety and efficacy of the RDN off-med trials showed that RDN is having a scientific evidence of efficacy in lowering the blood pressure. And if we look at on-med trials, that showed that the scientific evidence of efficacy is there in a clinical relevant population when the patient is already on the antihypertensive agents. And the global simplicity registry showed a large data set including multiple subgroups, providing a longer duration of the effect and longer duration of the safety also in a real world settings. Now, which patients are more likely to benefit from RDN? Because the effect of RDN is not homogeneous. If we see the success rate of RDN, only 4 out of the 5 patients will respond, 1 patient will not respond to the RDN. So, how to pick up the responders versus the non-responders? The various postulated theories are like, look at the individual's hypertensive pathophysiology. To what extent their sympathetic nervous system is contributing to their hypertension. If there is a more of sympathetic drive which is causing hypertension, so there may be chances that these patients will more respond to the RDN as compared to the others. Then looking at the individual's anatomy, what is the diameter of the renal artery? What are the number of accessory renal artery? How feasible is to reach the distal part to have a successful ablation? So all these will define whether the RDN will give you a good outcome or not. And the third is the operator's expertise. If the RDN is done at the center where the operational techniques and expertise is good, then obviously we can have a good successful data. So identification of the right candidate and trained operator is very important if we want to have a good response for the RDN. Now coming to the indications for the RDN is already discussed: uncontrolled hypertension or resistant hypertension, or if the patients having increased sympathetic or drive. There is no such objective evidence how to calculate in which patients will be increased sympathetic drive. Either patient could having a resting high ambulatory heart rate. The data have shown that the heart rate of more than 74 beats per minute, these patients are more likely to respond to RDN as compared to the other person. Similarly, if you can measure the noradrenaline spillover in the kidneys, or if you can measure the renin levels. If the renin levels are high, this means these patients they are more likely to responsive to RDN. And the other things where the sympathetic overdrive is contributing to hypertension is the early morning hypertension, nocturnal hypertension. So these patients are going to have response with the RDN. The third one is the sleep apnea syndrome. Though it is a secondary cause of the hypertension, but in sleep apnea at the time of hypoxia in the night time, there is a neurogenic activation, so which is a kind of sympathetic activation and contributes to the nocturnal rise in the BP. And if the patient is having orthostatic hypertension, obese patient they have increased sympathetic drive with high heart rate, younger adults as compared to the elderly where arterial stiffness is on the higher side. So whether the increased arterial stiffness patients, they will be more responsive to RDN, that needs to be explored more. But in global simplicity registry, which is a 3-year data, they have shown that the patient even with the isolated systolic hypertension, they have a good response to the RDN. So with the success of all these trials of the RDN, so there has been a change in consensus statement. In 2018, European Society said that it should be used only for the research purpose. Then subsequently all the trial results came in 2021 and 2023. There has been a change in the guidelines. I will be highlighting only few consensus statements. Asian Consensus Panel recommendation says that RDN can be a way to reduce blood pressure, either alone or in combination with medication for the Asian population when the blood pressure targets are difficult to achieve, provided there is a proper procedural training and expertise is available. And always look at the patient's cardiovascular risk. Suppose uncontrolled hypertension with high cardiovascular risk, already having a cardiovascular factors, these patients should be prioritized for the RDN if they have uncontrolled blood pressure. Similarly, if the patient who is having uncontrolled blood pressure in the form of nocturnal hypertension, masked hypertension, or some kind of intolerance or some kind of problem with the adherence, these patients should be prioritized. And always the patient preference should be kept in mind. Thai Hypertension Society says that refractory hypertension is class 1 recommendation. Resistant hypertension with high cardiovascular risk or high hypertension mediated end-organ damage, which is 2A recommendation. Resistant hypertension with evidence of drug resistance or drug adherence problems, 2B recommendation, but routine use for the blood pressure control is not recommended. This is a major change in the European Council statement in association with the percutaneous cardiovascular intervention, which says that RDN can be used as a treatment option in uncontrolled resistant hypertension, provided we are ruling out the true pseudo-resistance and in patients who have fully compliance with the lifestyle and medication. But that should be done in a shared decision-making process. The person should be informed about the risk and the benefits of the procedure, and also the patient's global cardiovascular risk and end organ damage should always be examined. Apart from this, these RDN trials, they have been indicated only in the persons with GFR more than 40. Below GFR 40, it is not recommended, and in the absence of evidence, it is not recommended to perform in kidney transplant recipients in severely impaired kidney function requiring hemodialysis, or the persons who are having untreated secondary hypertension and fibromuscular dysplasia. Patient education is very important. If they are going for RDN, they should be informed that they will not be free from antihypertensive patients. One RDN will be equivalent to free from one antihypertensive patients, but might be chances they will be having 1 or 2 drugs in the future. And the patient should expect to see the results not immediately after RDN. It will take time, maybe 4 to 6 weeks time for the effect to come, but they can be ensured that this effect will be more incremental as the time will pass. But still many open questions are there because it's a new modality. We don't have much data in India. How to identify a responder, how to pick the responders, which patient should undergo RDN, what are the procedural endpoints, how we can get to know that the RDN has been completed. This is the last slide. How to have more complete and circumferential ablation of the renal nerve, and RDN in patients with comorbidities, how reduction in blood pressure can be translated to have a good cardiovascular outcomes, safety in patients with lesser GFR, and what is the effect of the RDN in Asian population, and the potential role of RDN in patients with other conditions having high sympathetic drive, like patients having obesity, metabolic syndrome, heart failure, atrial fibrillation, etc. And if one patient is unresponsive to RDN, whether there will be benefit of repeat RDN in the same procedure. And the other important thing is denervation of organs other than the kidneys. Will it be helpful for the resistant hypertension? So coming to my last slide, after years of decades of research, RDN has now come of age with good efficacy and safety data. It can be considered in patients with treatment-resistant hypertension and also in patients with masked hypertension, poorly-controlled early morning and nocturnal hypertension, poorly-controlled hypertension with high cardiovascular risk, especially with where we have issues of poor drug adherence and intolerance. So maybe in the coming times, RDN may earn the title of third option in the armamentarium of antihypertensive treatment in resistant uncontrolled hypertension, but in appropriately selected patients, and that too on shared decision basis as a part of structural treatment strategy, and that too in the hands of a well-trained interventionist. So at least RDN has gave a hope that after the medication, when nothing is left, this can be a tool which can get a recommendation in the coming guidelines too. Thank you so much for your patience for listening.
Thank you, ma'am. For the next speaker, I would like to announce Dr. Anurodh Dadarwal, consultant cardiologist at IV Hospital.